While there is general agreement regarding the principles of antimicrobial therapy, the implementation of those principles is often difficult in practice. Nonetheless, these principles provide a basis that allow the clinician to optimize outcome in patients suffering from infectious diseases. In general, the use of antimicrobials can be considered either prophylactic, preemptive, empiric, or definitive. Antibiotics are used prophylactically to prevent infection, preemptively to abort infection, empirically to provide initial control of infection in the absence of specific data, and definitively to cure infection of a known etiology. Some examples can be seen here. Examples of prophylactic antibiotic use in the outpatient setting include the prevention of endocarditis in at-risk patients undergoing high-risk dental procedures. In the inpatient setting, antibiotic prophylaxis to prevent postoperative surgical infections is another important example. Perhaps the commonest use of preemptive therapy occurs in immunosuppressed transplant recipients to prevent the development of end organ infection in patients with cytomegalovirus circulating in their blood. In the outpatient setting, the most common use of empiric therapy is in acute sinusitis and community-acquired pneumonia. In such patients, one almost never knows the precise etiology of the infection, or especially in acute sinusitis, whether it's actually due to a bacteria. In the initial management of urinary tract infections, antibiotics are administered empirically, but then may be altered depending on the results of culture. In the inpatient setting, the use of empiric antibiotic therapy is widespread and includes patients with community and hospital-acquired pneumonia, fever with neutropenia, undifferentiated sepsis, and the like. And finally, definitive antibiotic therapy is tailored to treat any infection in which the etiologic pathogen and its antimicrobial susceptibility pattern are known. We will now focus on empiric therapy, and more specifically on empiric therapy in sepsis. An important element is choosing the appropriate antibiotic or antibiotics to administer in the critically ill patient with sepsis. That antibiotic must be administered as rapidly as possible, and in fact, in patients with septic shock, there is evidence that there is an almost 8% increase in mortality for every hour in delay in initiation of appropriate antibiotic therapy beyond the first hour. In this setting, appropriate refers to antibiotics to which the pathogen ultimately proves to be susceptible. Another element, an important element in deciding which antibiotic or antibiotics to choose empirically include the site of infection and the likelihood of antibiotic resistance. Defining the site of infection may allow for the possibility of source control, if, for instance, in the presence of abscesses, and also give you clues as to the likely pathogens. Clearly, the likely pathogens are different in suspected urosepsis than they are in the patients with pneumonia as the source of their sepsis. Should also assess the likelihood that the pathogen causing the infection is resistant to many commonly used antibiotics. Elements which might lead one to have that suspicion include a history of recent antibiotic exposure, known colonization with antibiotic-resistant pathogens, frequent exposure to healthcare facilities, and knowledge of local antibiotic resistance patterns. Also to be taken into account are host factors. Some of these, for instance, might preclude the use of individual antibiotics. For instance, patients who have life-threatening allergies to a particular antibiotic or class of antibiotics. Also, things that might steer one away from certain antibiotics is an increased risk of antibiotic toxicity. Examples of these are the use of nephrotoxic agents such as aminoglycosides or amphotericin in patients who already have marginal or unstable renal function. Of critical importance in the decision-making process is an assessment of the severity and trajectory of illness. How sick is the patient, and how rapidly are they likely to deteriorate? What, in fact, is the margin for error? If I give the wrong antibiotics today, will the patient still be alive tomorrow? This sort of assessment dictates a lot of the decisions that are made in the management of the patient. In general, certain recommendations are also of importance. The first one is to ignore colonization and to only treat infection. To try to obtain cultures before the initiation of antibiotic therapy, but do not inordinately delay the institution of antibiotic therapy in order to obtain those cultures. In instances with sepsis, blood cultures can almost always be obtained prior to the initiation of antibiotic therapy, but in contrast, respiratory specimens may be more difficult to obtain, and one should not delay the initiation of therapy in order, for instance, to obtain a sputum specimen. Administer that first dose of antibiotic as quickly as possible, and then to not stop there, but to continually evaluate the appropriateness of your choice of antimicrobial therapy. An important cutoff is at 48 to 72 hours, at which time much microbiological information is available, as well as clinical information indicating the patient's current status and evolution. In fact, the most recent iteration of the Surviving Sepsis campaign has provided guidelines with regard to initiation of antibiotic therapy and its repeated evaluation. They state, for instance, that in patients with septic shock or severe sepsis without shock, the administration of effective intravenous antimicrobials within the first hour of recognition should be the goal of therapy. They also state that the antimicrobial regimen should be reassessed daily for potential de-escalation to prevent the development of resistance, to reduce toxicity, and to reduce costs. De-escalation, however, is not the only potential decision that might be made at that time. Other alterations must be considered as well. And in the consideration, one must take into account all the elements involved here, put in a simple fashion as the bug, the drug, and the host. So that one, as I've indicated, should be taking antibiotic timeouts on a regular basis, analogous to the timeouts that are now used in the operating room. And in this timeout, one should reevaluate antibiotic therapy based on the clinical response and the microbiological data as it becomes available. The identification of the organism, the susceptibility of the isolate, and in the interval between knowing there's an organism and perhaps its identification and the availability of the antibiotic susceptibility data, to use the local antibiogram to make any decisions about alteration of your initial empiric antibiotic therapy. So, having done this antibiotic timeout, a number of possibilities exist in terms of the patient's clinical status and culture results. So, in this first one, the question is, what does one do during this reevaluation if the patient's cultures are negative? Obviously, you evaluate the clinical status. And there are three possibilities. There could be no improvement, the patient could be improved, or in fact the patient's clinical status may have worsened. Let's take the case in which the patient is improving. At that time, it's still important to reevaluate the antibiotic dose, to eliminate redundancies in coverage that might have been started, and to evaluate for adverse effects of the antimicrobials. Then we consider whether the culture is positive or negative. In the instance in which we have positive culture results, we will refine that therapy. If they're negative, we may either continue the therapy, modify it, or in fact discontinue it depending on clinical status and other information that's available. In the instance where cultures are positive and the patient is improving, we should refine our antimicrobial therapy. We should resolve any bug-drug mismatch in terms of antimicrobial susceptibility. We may be able to de-escalate therapy by eliminating those redundancies I mentioned, by narrowing the spectrum of antibiotic therapy. We should optimize our dosing and consider in some cases whether therapy can be, for instance, switched to the oral route. And it's also time then to plan the likely duration of therapy. The duration of therapy can depend on a number of factors. Sometimes clinical scoring or biomarkers can be useful. So, for instance, the clinical pulmonary infection score is commonly utilized in ventilated patients with pulmonary infiltrates to decide whether the pulmonary infiltrates are actually caused by infection or any of the multiple other causes that can produce chest x-ray abnormalities in the critical care patient. The CPIS score takes into account some simple measures such as temperature, white count, tracheal secretion characteristics, the PaO2 to FiO2 ratio, and the chest x-ray abnormalities. The CPIS score, in addition to being evaluated initially, can be used after 3 days of therapy to decide about potential de-escalation. And one clinical trial has demonstrated the efficacy of this in actually discontinuing antibiotic therapy after 3 days in patients with low CPIS scores. Another approach is the use of biomarkers, which might allow one to discontinue antibiotics, and the one that has most widely been evaluated and which seems to have the most promise is the use of procalcitonin levels. There is also empiric therapy, empiric data that allows us to decide how long to treat certain types of infections. So, for instance, current guidelines indicate that community-acquired pneumonia can be treated for at least 5 days. Therapy could be stopped as early as 5 days. In ventilator-associated pneumonia, in most cases, 8 days is sufficient, although there is some concern of increased risk of recurrence in patients who are infected with non-fermenting aerobic gram-negative rods such as Pseudomonas aeruginosa. And another, outside the realm of pneumonia, an infection such as Staph aureus in the bloodstream, in which there's a removable focus. So, for instance, line infection associated with Staph aureus can be treated for just 14 days, as opposed to much longer courses of therapy in circumstances where endocarditis is present. All of this is useful information, but it really depends on our clinical astuteness and judgment, and our understanding of the uncertainties, as quoted by William Osler, as in quoting William Osler, who said, "Medicine is a science of uncertainty and an art of probability."